Hello, everyone. This is my first time coming to this conference. I am Melissa Wellons. I am an associate professor of endocrinology at Vanderbilt. And I thought I was going to be having a conversation with you today, but the room is pretty full, so I will just sort of give you my perspective on endocrine care in women. So my background, I really entered this area as a researcher. I did training, I did medical school, and then I went on to have a research career focused on the relationship between ovarian function and cardiovascular disease. So that really informs a lot of my practice. So at Vanderbilt, I see women's health patients with ovarian issues that include Turner syndrome and polycystic ovarian syndrome. I also teach medical students. I was in charge of the first-year medical students' endocrinology block this past year. So a lot of how I talk will reflect my work with medical students. So I love talking about physiology. So you will get some medical student lessons today. And so in any presentation I give on a national stage, you usually start with a case. So you'll just learn this is the way the medical field does things. In the case I have, some of the details have been changed, but it is very similar to a patient that I've seen fairly recently. Was a 23-year-old woman, and she came in with a primary complaint of irregular menses, commonly what I see. And she was referred to me by another endocrinologist in my practice who was in the process of working her up for high blood pressure. The patient reported that her menses had begun at age 11. They'd become irregular and were heavy. They'd started getting irregular around age 16, but they had been absent for the past 3 months. Other past medical history, nothing of significance for today's presentation. She wasn't on any medications, and so physical exam was generally normal, except for what my colleague was seeing her for. Her blood pressure was high at 155 over 105. She was 4 feet 11 inches, which was less than expected given her parents' height. Her body mass index was above ideal in the overweight range, which is between 25 and 30. But otherwise, a normal exam. And so this is sort of that medical student teaching. One of the first things I do is check labs in the patients that I see, and the labs I was interested in her were labs that have to do with how the ovary is functioning. So this is sort of the medical student slide for endocrinology, but you have the hypothalamus in the brain that stimulates the pituitary gland to make hormones that are released and distribute through the circulation to stimulate target glands, one being the ovary, to do something. And so in the case of we call it the HPO system, hypothalamus pituitary ovary system, pituitary gland secretes follicle-stimulating hormone to stimulate the ovary to release eggs and make estrogen. And so I checked a follicle-stimulating hormone level in this patient and an estrogen level in this patient. And her estrogen, having not had menses in 3 months, was low, and her follicle-stimulating hormone was high. And that makes sense. The estrogen's not feeding back to the pituitary. Pituitary's pushing on the ovary to try to get it to make more estrogen and release an egg. Also, I've done a lot of research on trying to identify biomarkers that can estimate how many eggs or oocytes are in the ovary. And one of these proteins is a protein called anti-Müllerian hormone. So ovaries are typically, on average, in a 23-year-old like here, full of oocytes or eggs. And those eggs, represented here in the middle of this image, are surrounded by cells called granulosa cells Those cells contain a hormone called aromatase. You may have heard of aromatase inhibitors used in breast cancer to shut down estrogen, because aromatase takes testosterone made by the cells surrounding those cells. So these cells on the outside make testosterone. An enzyme in the next layer takes that testosterone and converts it into estrogen. And over the reproductive lifespan of a woman, these, what are called follicles, these units, deplete over time. And in the United States, the average age of menopause in this country is 51. And that's the time when all of the oocytes have been depleted. Some people have depletion of those oocytes earlier than average, women with Turner syndrome being one of those groups. So for her, I checked a level of a protein made by those granulosa cells, and it was undetectable, suggesting that her supply of granulosa cells, follicles, eggs was exceedingly low. Also ordered a karyotype on this patient, and she was missing a piece of one of her X chromosomes. And would be categorized, I think, within a group of women known as having Turner syndrome. And so, I told you before, my primary research has been on ovarian insufficiency, that is, women who experience menopause before the age of 40 and its relationship with chronic disease. And so the definition of primary ovarian insufficiency is having hypergonadotropic, which means high follicle-stimulating hormone. Your pituitary gland is working hard, it's got high levels. Amenorrhea, lack of menses, before the age of 40. And the formal diagnosis is at least 4 months of lack of menses, having follicle-stimulating hormone documented 2 times in the high level, and low estrogen. And then essentially it's reflecting a loss of these units in the ovary. And women have lack of eggs and a prematurely low estrogen level as compared to the average American woman who goes through menopause at 51. This occurs in approximately 1 in 100 women in the United States, and women with Turner syndrome are a subset of this group. The data I found in a really great review article in Nature Reviews Endocrinology by Grabholt, who I see writes a lot about women with Turner syndrome, said that the prevalence of Turner syndrome in this country is 1 in 2,000. So of the 1 in 100 women who experience this, about 15% of these women are diagnosed with Turner syndrome. Most primary ovarian insufficiency, we currently don't understand the underpinnings of it. So this has been my major interest, is how does a loss of ovarian reserve, egg supply, cells that produce estrogen, cells that produce other things, those cells around the eggs, how does that associate with the development of chronic disease? And so epidemiology has shown, again, I told you average age of menopause in this country is 50. So average age of loss of eggs is 50. Women who have a later age of menopause have more reproductive cancers, more breast cancer, ovarian cancer, endometrial cancer. Women who on average experience it earlier have more cardiovascular disease, obviously less fertility due to a lack of eggs, and more bone health issues. So how does this relate to Turner syndrome? Data that I read preparing for this, epidemiologic studies have shown that women with Turner syndrome have a shorter lifespan, at least in the past, than the average woman. So if the average American woman lives to be 76, it seemed in the past that women with Turner syndrome lived 13 years less. That has not been seen in a more recent epidemiologic study done in Europe among women who've been treated with growth hormone and received other medical treatments. But most of the higher morbidity, higher deaths, higher issues were related to an increased risk of cardiovascular disease among women with Turner syndrome. I wrote my own notes here. I think hip fracture probably also contributes. A lot of times when we look at death certificates in the epidemiologic world, things like hip fracture wind up resulting in heart disease. People become debilitated, they don't move, they don't exercise, they gain weight. And so what started as a hip fracture may later look like a problem with the cardiovascular system. It is noted, going along with this epidemiologic curve, that women with Turner syndrome tend to have less reproductive cancers, less breast cancer, really we're probably reflecting that less exposure to hormones over the lifespan, or specifically estrogen and progesterone. So this is my I get to talk, and so this is my area, but it is cardiovascular disease prevention. And so when we talk about major risk factors for cardiovascular disease, the common ones that everyone should know, it's blood pressure, cholesterol levels, specifically the bad cholesterol, LDL cholesterol, the good cholesterol, the HDL cholesterol, tobacco use, and diabetes are the main ones that come up. And so with regard to what I call among those traditional cardiovascular disease risk factors, the ones that are more prevalent among women with Turner syndrome are, first of all, the ones I call the vessel health issues. So that is the reactivity of the vessel wall seems to be more commonly dysfunctional in women with Turner syndrome, and there is a very high prevalence of high blood pressure among women with Turner syndrome. There's also a higher prevalence of aortic disease, and often discussed is a higher risk of aortic dissection that seems to be stressed in the setting of pregnancy. And there's actually someone tomorrow I saw speaking about aortic health, Dr. Siddharth Prakash. And I think that would be, if you want more information specifically about aortic health among women with Turner syndrome, I would definitely want to go to that presentation. In terms of, and I speak at national meetings a lot about cholesterol levels and the relationship with the ovary and with heart disease. So in terms of the cholesterol levels among women with Turner syndrome as compared with other women, if you look at these were two separate studies that I cite here, where women with Turner syndrome were compared with other women with primary ovarian insufficiency, and then a second where I show women with primary ovarian insufficiency compared with women without either. And this shows that among women in their 30s with body mass indices that are similar, women with Turner syndrome tend to have higher total cholesterol than women without either POI or Turner syndrome, and women with POI are somewhere in between. Women with Turner syndrome have higher levels of LDL cholesterol, so the bad cholesterol. Everyone here seemed to have similar levels of the good cholesterol, and triglycerides were higher among women with Turner syndrome, again, with sort of a dose-dependent going up toward from the controls versus the POI versus Turner syndrome. So there is this association. I know a lot of what we were expected to talk about today is hormone therapy, but whenever I talk to any women in my clinic about hormone therapy, be they women with Turner syndrome, POI, or women going through menopause at more average ranges, one of the main things I do say is the current evidence does not suggest that using hormone therapy is a treatment for cardiovascular disease. It is not considered a risk-lowering therapy. We do not recommend it. It is not in the U.S. Preventive Services Task Force guidelines. This is not a therapy that is used to prevent heart disease. But your risk of heart disease does play into decision-making around choosing hormone replacement therapy. Heart health, the major things that women with Turner's syndrome and any woman in this country, everyone should do to promote heart health is have a good lifestyle. And so that is exercise and a good diet. And these are sort of my simple recommendations. But I do sometimes just write up a prescription for every single patient. You should be exercising 150 minutes a week to the point of breathlessness. To a heart rate of 220 minus your age times 0.85. So for a 25-year-old woman, that is exercising 150 minutes every week to a heart rate near 165. And eating a heart-healthy diet. High fiber, low saturated fat, more detail. It seems to be this is what our nutritionists say is a lot of oatmeal, keeping up with your saturated fat, and making sure you're eating lots of fruits and vegetables. These are the main things in young life and midlife to be doing to protect yourself against heart disease, lower cholesterol, and improve those cardiovascular risk factors. Hormone therapy. I'm realizing I probably need another slide to talk about the reasons you think about hormone therapy in women who have prematurely lost estrogen, lost these hormones. We know that hormone therapy, estrogen therapy, is needed to maintain good bone health. That's probably the biggest driver, is that estrogen is needed to achieve peak bone mass, which we think occurs in the early 30s. So you want to have estrogen on board to get your bones to peak bone mass and then to maintain them as healthy as you can. And the evidence for estrogen for that purpose is strong. Other things that estrogen is important and there's evidence that it protects from or helps with is maintaining uterine health, and the size and health of the uterus. And also, for the average woman going through menopause, 50% of women experience vasomotor symptoms, hot flashes, night sweats, vaginal dryness. And for women who have those symptoms at a moderate to severe level, which is defined for hot flashes as 8 to 12 a day, then estrogen therapy reduces those vasomotor symptoms. Those are the predominant reasons that I prescribe hormone therapy to people for evidence-based reasons that estrogen helps. And the types of hormone therapy that are available to me as a prescriber are birth control pills and what we call, for lack of a better word, menopausal hormone therapy. Birth control pills contain ethinyl estradiol and some sort of progesterone, and menopausal hormone therapy, the preparations are typically 17 beta estradiol, which is what your ovary naturally makes, conjugated equine estrogen, which is a estrogen derived from horse's urine. Those are the two main types of estrogens that are used. Conjugated equine estrogen is taken by mouth. 17 beta estradiol can be taken by mouth or given in a transdermal or through the skin some way. These medications, if a patient has a uterus, must be given with a progesterone to protect the lining of the uterus. So estrogen grows the lining of the uterus, and progesterone stabilizes the growth of the lining of the uterus. Without progesterone on board, when a woman is taking estrogen or exposed to estrogen, the lining of the uterus can thicken and build up. and is at risk of developing endometrial cancer. So you have to have progesterone on board to check the effect of estrogen on the lining of the uterus. Birth control pills. So on the left, back to my medical student teaching. On the left side is a graph of an average menstrual cycle. On the top are those pituitary hormones, luteinizing hormone and follicle stimulating hormone produced by the pituitary gland. You see them being produced along of the first 10 days of a cycle, and that follicle stimulating hormone stimulates the ovary to make estrogen, and levels of estrogen go up, and start growing the lining of the uterus. At the midway point of the cycle, typically an egg is released, and the cells that surrounded the egg switch to making progesterone. And progesterone is seen here in red. Progesterone stabilizes the lining of the uterus, and then when it drops off, that signals the system to bleed and shed the lining of the uterus. That is the typical hormonal cycle of a 28-day menstrual cycle. On the right is what happens with a birth control pill. So a synthetic, taken by mouth, synthetic, a thionyl estradiol that I showed you, synthetic estrogens taken by mouth along with the progesterone, and they just shut the pituitary down. Just suppress these hormones all the way down, and so you'll see it's just flat. And then estrogen, estradiol, goes down. So the ovary's natural production of estrogen goes down, and that synthetic estrogen is just given throughout the month. Here, shown in red, a synthetic progesterone's given. It's given, it ramps up, the level ramps up, and then when that progesterone level drops, the lining of the uterus is shed. And that's how a birth control pill works. Its goal is to shut down ovulation, shut down the system, and it creates a cycle by giving progesterone for 21 days and then dropping it off, and that stimulates the lining of the uterus to be shed. Birth control pills have been around for a while, and so we're now on our what we call third generation of birth control pills. In the early days of birth control pills in the 60s, they contained much more estrogen than they contain today. And so the doses have dropped over time. Currently, the lowest dosed birth control pill on the market contains 10 micrograms of a thionyl estradiol. And I just put here, this is in contrast to, again, just what we call it menopausal hormone therapy, which is about half or a fourth of that dose. This dose, menopausal hormone therapy, is more average to what a cycling woman is exposed to on average over a month, whereas a birth control pill is higher to suppress those hormones from causing ovulation. The reason birth control pills' doses of estrogen have dropped is because we have learned, as experienced clinicians and pharmacists and clinical chemists, that some of the risks of the therapy, all therapies have risks and benefits, some of the risks of the therapies decrease with decreasing dose of estrogen. The main risk of estrogen therapy is clotting. And so whenever I talk to patients, any patient, about taking a birth control pill, I say, if you came in off the street, your chance of developing a blood clot in your leg or in your lung is 1 to 3 in 10,000 in a year. If I give you a birth control pill, and this is for a reproductive age woman, so this is 20 to 40. If I give you a birth control pill, it's double or triple, so 3 to 9 per 10,000. This risk is lower than if you're pregnant. If you're pregnant, it's 20 to 60 in 10,000. So your risk with a birth control pill is lower than getting pregnant. It's higher than you came in with. And those are the risks that we're contemplating. I just gave a talk with a cardiology crew. So I know this is dense, but I just talked about the thrombotic risks, the venous thrombotic risks. Arterial clots, heart attack, stroke, they are thromboses as well. And so this was the best data I could find. This is a large epidemiologic study of all the people of Denmark. They do a good job of getting data on everyone in their population, and they know what medicines their population takes because they track all the prescriptions, and I think filling them was probably free. And so in the Danish population, they showed that the baseline risk of stroke and heart attack in the reproductive age population of women ages 15 to 49 was 2 per 10,000 for stroke and 1 per 10,000 for MI. And with use of a birth control pill at a dose of 20 micrograms, the risk was 1.5-fold increased. So it would be, it would increase it from 2 to 3 per 10,000. Or from 1 to 1.5 or 1.7 in 10,000, and then was almost double with the use of a higher dose. And so mostly this is just evidence to say these data on heart attack and stroke just track with what you would expect based on looking at the data on venous clots. And this is just risk that we accept as, and there was an editorial that said, yeah, it's increased, but just it is. This doesn't seem exceedingly so. These are low risk events, but it still does affect clotting. So it's just something to be knowledgeable of. So again, my focus is on cardiovascular disease. So I'm very interested in the effects of hormone therapies on the risk of stroke and the changes that they have in cardiovascular disease risk factors. So these are studies in women in their 40s of different preparations of the menopausal hormone therapy, the 17-beta estradiol and the conjugated equine estrogen, given in either a patch form or oral form. And this is just a slide to show in general, in the menopausal hormone therapy doses, that lower dose of estrogen therapy, they generally have a neutral effect on blood pressure. If estrogen is taken by mouth, it improves LDL cholesterol. If it's given in a patch form, it's neutral on LDL cholesterol. So anything you take by mouth, when you take estrogen by mouth, it affects things that are processed in the liver, and it has some good effects on cholesterol metabolism, has some negative effects on triglycerides. But when it's going through the liver, we call it the first pass effect, it is affecting lipid parameters. That was the data on the right. This is in women in their 40s. And, a lot of medicine is extrapolating reasonable data from one group to another group. I showed you all that data about Danish women, but it's still, it's the best data we have. We find it relevant to our practice. So on the right are women in their 40s. This on the left is actually specifically a study of women with POI, some I think who did have Turner syndrome, comparing specifically the effect of birth control pills versus transdermal estrogens and their effect on the cardiovascular system. And specifically what they did see is that the use of a transdermal preparation of estrogen had less effect on blood pressure than a birth control pill used in those populations. So that's my main point with this slide is we do have some data in women with POI that using a birth control increases blood pressure more than a transdermal preparation would. And so my overall take-home points for cardiovascular disease is the number one killer of all women in the United States. Risk of cardiovascular disease appears higher in women with Turner syndrome. Primary ovarian insufficiency, Turner syndrome may represent a group at high CVD risk. Traditional CVD risk factors are often worse in POI, more high blood pressure, more deranged lipids with higher LDL. If I could tell you to do anything, I would recommend lifestyle modification as early in life as possible, carrying those good behaviors forward with you for the rest of your life. Hormone replacement therapy is not a treatment for cardiovascular disease, nor is it a preventive therapy for cardiovascular disease. But thinking about how the cardiovascular system is affected by this therapy should be taken into account when choosing therapy for all the reasons that a woman is choosing it. So overall, in using hormone therapy, the goal is overall wellness and balance. And this was another really great article I read in JCM by Klein on estrogen therapy, specifically in Turner syndrome. But they talk about it. It remains unclear if hormone therapy should be indicated before a certain age in order to achieve maximal benefit of treatment. I've talked extensively about cardiovascular system. Again, there's clear evidence of benefit of hormone therapy on bone health in women with Turner syndrome in affecting the growth of the uterus. Other topics also came up in this review: liver function, neurocognition, sexual function. But the evidence of use of treatment, the use of estrogen therapy and study of that, I found that lacking. Studies actually looking at the therapies and how they change these outcomes were not there. So in balancing health and wellness, the things I think about are vasomotor symptoms, bone health, uterine health, and then weighing cardiovascular risk in it. Evidence for bone health in Turner syndrome. There obvious. I've said this again. There is obvious evidence for benefit of menopausal hormone therapy, no matter what, for the treatment of bone health in women with Turner's. And then there have been studies showing that transdermal preparations may be superior to birth control pills in maintaining bone health in women with Turner syndrome. And strong enough advice that the European Society of Human Reproduction and Embryology said this is the therapy that they favor in women with POI over birth control pills for bone health. And it was at a dose of 100 to 150 micrograms. I said again, Grab-Holt had a nice review when they talked about reasonable therapies, reasonable regimens for treatment of women with Turner syndrome. They sort of resupported transdermal estradiol at a dose somewhere between 50 to 150 micrograms a day, or oral 17-beta estradiol. Again, must have a progesterone on board if a uterus is present to protect it from endometrial overgrowth. And, these are expert opinions, but the discussion is it seems rational to continue therapy or consider therapy until the average age of menopause in this country, which currently is 51. So these are sort of my last general points. But good lifestyle's key. There's evidence for bone and uterine health. Evidence for estrogen and the prevention of cardiovascular disease is not strong. These are topics that I know other people at this meeting are talking about. So when family building plans include pregnancy, you need to be weighing things like vessel health and thinking about vessel health, aortic health, blood pressure, want to be thinking about maximizing uterine health. And that, in summary, experts agree that estrogen therapy, replacement therapy until the average age of menopause in this country seems a reasonable strategy. That's it. So that's me, and I'm happy to take questions now. How are we on time?
Well, we got.
Do you want to facilitate who to put my eyes down, or I looked at you the most, so you get to ask the question. A friendly face, you're very friendly.
Actually, you'll find every person in this room.
I'm sure.
Here's my question for you. So my daughter, who is now 19, when she was 12, and I'm going to pronounce this incorrectly, She had a laparoscopic oophorectomy. She had streaked ovaries, right? So they were removed. Right now, she's just taking birth control pills for her hormone replacement. So what I think I'm taking away, and correct me if I'm wrong, but this is a conversation obviously we'll have with her doctors, is should she be really transitioning to more menopausal kind of thing, even though she's only 19 because her ovaries were completely removed?
So, I'll just say in my women's health practice, polycystic ovary syndrome, 10 in 100 women. Premature ovarian failure, 1 in 100. So I'm going to be seeing 10 to 1 PCOS to ovarian insufficiency in my clinic. But in my clinic, I structure all my women's health visit. The first thing I have is family building plans. Like, let's talk about family building. Let's talk about where you are with that, because that influences hormone therapy for. I think in this setting to think about uterine health, which I'm not the expert on. I'm going to bring in an OBGYN on that. I'm talking in POI about bone health, and we've got this data that seems that 100 micrograms of transdermal, there's something about that seems good. That seems consistent in other fields, eating disorder fields, other things where it's coming up. And then I'm thinking about metabolism, and that's just all very personalized. And I think family building's a part of it. Your family history of breast cancer, cardiovascular disease, those things are coming in, and you're just trying to get a whole personalized view of the situation. So I would say those are the things I'm thinking about. When to transition from more of a birth control pill, thinking about that, yeah, something to talk more. Some people just want a birth control pill. And these low-dose birth control pills are pretty similar, but they're just risks and benefits, some convenience, some lifestyle that I'm always taking into account too.
Okay, thank
How about yes.
Okay, I just turned 60 in January, and I was born with no ovaries. I'm not taking any hormone replacement right now, but I'm having severe hot flashes at times. What if anything, should I be taking?
So, if this would be something to discuss with your primary care doctor, thinking about the other things that can contribute to hot flashes. And they've just come on now, is that, or they were?
I've had them for probably a couple, 2-3 years now.
And so, I would talk to your primary care doctor. I mean, if they decide that these are estrogen-related hot flashes, then, there are recommendations from, I think the best one's probably from the North American Menopause Society about treatment options for estrogen-related hot flashes. And there was actually just something in JAMA or the New England Journal of Medicine this week about who to consider therapy in. And 10 years out from menopause, age 60 was in a category of looking at other therapies other than estrogen. But again, this is just based on what I just read.
It was possible for me to be having hot flashes at 60.
Some people have them till 80, but it just working with them to identify the cause of it. I know they show there's like the epidemiologic graph, right? And then the people that you're like, oh gosh, they're 88 and still having them. All right.
One of the questions that I had is I was on the birth control oral since the time I was 16 up until I was in my mid-30s. And then what they found out was happening was I was having high cholesterol, so they put me on a cholesterol medication. I was having high blood pressure, so they put me on a blood pressure medication. And then they found out that my liver and lipids, I think that's what
or HDL, LDL liver function,
sure.
or okay.
They were
Triglycerides? Or something. Okay,
like
yeah.
3 times what they should be.
Okay.
And so they switched me from the oral contraception or oral estrogen to the patch. Well, what I noticed was that since I started taking doing the patch, that I have actually become more tired. My liver functions have improved because the numbers are going down as they should. But I am constantly tired. I am having the hot flashes. And constant, I am always tired.
I love when, my goal, if I could say, I would love to stamp out fatigue in women, right? We all need more energy. All of us. And so it is something I really do care passionately about. Physicians and researchers and medicine docs, we like tangible outcomes. And so it's death, it's heart attack, it's stroke, it's pulmonary embolism. And, I am well aware that life is more than worrying about those things all the time. But we just need better tools to get at what the fatigue is so that we can look and then do a randomized trial and measure it and see if it changes so that we can tell people meaningful things.
And that's kind of one of my questions.
Yeah.
And I've noticed it since I have started the patches is I am constantly tired. So my fear was that even though it's helping with my liver improve its function, now am I not getting enough estrogen? And is that what's causing?
And I think another thing to realize is estrogen receptors they're just all over the body. So there's some things that I work with. I have a cholesterol clinic, and there's a new medication out, and it's this little thing that's affected is only right there at the LDL receptor in the liver. And so you just know when you're giving something, it's so targeted. Estrogen receptors are all over, and it is a much harder whole wellness discussion to have, to just do our best to sort of put the information that we have together and listen to your story and just try to tweak it. And sometimes it's just trial and error to see, you can always do a trial of something for 90 days and go to something else. I'm going to go way in the back.
And then she's right.
Okay. Yes.
Okay, so just to see if I have this straight, the information that you've been seeing from your colleagues would almost support taking the patch over the oral?
Some of this is preparing today and looking at, I looked at major review articles and the 2017 guideline, and just my personal experience. But I'm myself, and I'm a product of the patients that I see. But currently, I am thinking more about whether that 100 micrograms of transdermal is beneficial. But I tend to present them to patients. I've never done a patient session or this type of session. I do try to present them as fairly neutral and try to think with the patient about what the pluses and minuses of each one is. But today, at this very moment, maybe I'm leaning a little bit more toward that based on the bone health issue. Yeah. Okay, we're going. Okay, yes.
So I've been going to an endocrinologist all my life, but they've always said that getting a test to see where my estrogen levels were always too unpredictable. So I've never had a test to see where my estrogen levels are. And I'm just wondering, what the heck? Because on your slides, you sound so sure that they're going to be pretty darn accurate.
Is the estrogen I guess I talk to patients about ovarian supply, egg supply. That's something I talk to adult patients about. That's the group of patients that I see. So I use the best tests I have available, including that anti-Müllerian hormone level, to try to estimate the amount of eggs in a woman's ovaries. women with the complete absence of one X chromosome, just X without the second chromosome. I've not had anyone have detectable egg supply measures so far in my practice. Now, in terms of estrogen levels, I'm not sure I get levels when I'm trying to figure out what's going on in someone's ovaries, but if I'm giving them estrogen therapy, I wouldn't necessarily be checking a level in that scenario, if that's what you're asking.
So that's like a thyroid level.
Always, and I love diagnostic testing, always, and again, teaching medical students, we're always looking for things that tell us what the level of a hormone has been for many months. And we're just trying to figure out smart ways of saying, how can we figure out how high this person's estrogen has been for 3 months? And we don't have that measure for estrogen right now. We have measures in diabetes that tell us what the glucose has been for 3 months, and we use those a lot. But right now, the estrogen test is just a snapshot. It's a moment-by-moment snapshot. And so maybe that's what plays in. Versus a thyroid hormone from the pituitary gland is usually pretty stable over 6 to 8 weeks. It's usually the same. So it's kind of a look at what your hormone level has been for many months. We tend to shy away from things that are moment-to-moment changes. But
and then right over there. You mentioned just briefly in your answer to someone else something about eating disorders and the patch therapy. What is the link between those and,
really, so I'm the ovary cardiovascular person, and we have at Vanderbilt a wonderful bone person, and we have somebody that's bone and is trained in eating disorders. So I don't want to misstate what I've heard her say and bring speakers in about. But I think there seems to be evidence that transdermal in the setting, I think it was of higher cortisol, and maybe higher cortisol is present in some scenarios, that there was some theory about transdermal estrogen being more beneficial to the bone in, as I remember, a setting of higher cortisol. But that's quoting someone else's expertise.
I've heard that we have tend towards something called fatty liver, and how does that fit in with the hormones and all that?
So when I talk to patients about if you have 2 little girls born and they're the same size around their midsection, and one has like an inner tube of fat in their midsection and all their organs are packed together, and a second child has adipose tissue, same amount of fat, but adipose tissue fat that's spread out throughout their abdomen. It's just sort of a genetic difference in how those 2 little girls are born. And the one with that peppered around tissue is more likely to develop diabetes and lipid problems, triglycerides, LDL, lower HDL, fat, because of fat in the liver, and those go together. And so that's what I talk about. I think that there's just a predisposition to what you're born with. But then I talk to people about we can do everything we can to sort of shrink down what is there. But some people just have, I think they're born with more fat deposited in their liver, and then it grows. That being said, there could be something that leads to fat deposition in the liver, but I tend to think of it more as something that just maybe expands over the lifespan. But it does, we do think that drives abnormalities in cholesterol levels. I have read some research that women with Turner syndrome do tend to move less and exercise less than others. So again, getting back to the lifestyle, if just try to say if there's a predisposition to not move, that sets that up to grow more. And so anything we can do to exercise and eat a healthier diet will mitigate that. The only treatment known currently for fatty liver is weight loss. So it's just losing that tissue. We don't have any medications, and there have been multiple randomized trials of metformin and other diabetes medication and statins to see if it can get that out, and that hasn't been shown so far.
Thank you.
We have time for like one or two more questions, and then we'll finish up.
Thank you. First of all, I'd like to say for the transdermal patch, I started mine in 2000. Blood pressure is a huge difference thinking about that. So that's just my personal experience that the patch is offering. My second question, what's your feelings, your thoughts on testosterone cream? Can that help with energy levels? The ovaries make testosterone, is that right?
The ovaries, so yes, so that follicle. It's a good question. So the ovary and the follicles in the ovary, it's that egg surrounded by the granulosa cells that make estrogen, surrounded by the testosterone, the cells that make testosterone, and so. I don't know the literature on testosterone specifically in women with Turner syndrome. I know there was one researcher at the NIH interested, and I thought doing a randomized trial giving it, but I haven't seen the result of that yet. I've followed literature in randomized trials of testosterone in women who've had their ovaries removed, and it was given specifically for libido, and those studies did not pan out. And it was by a company who wanted to get, a libido drug to market, and so that didn't pan out. I think it's a very understudied area, but it's not something. I kind of have that conversation. Like, we don't have a lot of evidence, and so I don't have a strong opinion. I can be someone who tries things and does an N of 1 study, and getting testosterone for women is that people haven't been able to really get it. It's very expensive, and I don't have good evidence to back up prescribing it. So it's really, I'm sorry to say, there's positive evidence, but something I think should be studied more. A great question.
And the one in the back in the green.
My daughter and I have had really good results using bioidentical.
You say that again?
We've had a lot of success using bioidentical hormones with there's no side effects because it goes directly to the bloodstream under the tongue, dissolve and so forth. And what do you know about bioidentical? I mean, I've been using it for 9 years.
So, I usually just say I'm a physician, and I don't know. My job is really to take the evidence presented to me really by the FDA and believe that the drugs that I'm using are regulated, and if someone's doing a bad job of manufacturing them, that they're shutting that plant down. I'm taking medications that with packages and explanations and really randomized trials showing that they do something. And so I'm taking that evidence and I'm pondering it, and I'm trying to present that back in a personalized way to my patients. And I have people say, so some people call bioidentical 17-beta estradiol. That's what the ovary makes, and there is FDA grade Transdermal 17-beta estradiol. So I prescribe that. If you're asking about compounded and made by like a local pharmacy, I just tell them, maybe I'm going to do that in my career later on when I can find a pharmacy that I know and trust, and I can go back there and sit with them and, do whatever they're doing and see what it is. But at this point in my life, I rely on governmental checks to to help me know that what I'm giving is what I think it is. Yeah. Yeah. It's really just, and I try to tell people I'm not a clinical chemist. Like, I don't make up my own medicines. I'm really just taking what's been made and putting it, using it appropriately. So. Well, transdermal doesn't. Well, it all goes through liver eventually, but transdermal, again, there are FDA regulated transdermal preparations that they go into the bloodstream first and they go through the liver later. So that's the first. They don't pass through the liver first. Like, you have to take a big whopping dose of estrogen to get it out of your blood into your blood system through your gut. So.
I will take one more question. I think we're back there and right there. Go ahead. Yeah.
Is there a reason to stop estrogen therapy before age 50, like say a stroke or something like that? Or maybe we can stop the therapy early?
Well, so in my practice, I'm usually weighing bone health, breast cancer risk, cardiovascular health, and I'm doing an assessment of those every time. And there's interesting information about the fact that people's family history changes over time, and it's not a static thing. And every time, somebody in your family can develop breast cancer at an early age. So you need to constantly be using that information. And so absolutely there are, if someone's risk of stroke or heart attack is high enough, I would start suggesting discontinuation. And so it's really at what threshold do you do that? And then, you're taking into account quality of life as well.
Well, thank you so much, Melissa.
Oh, thank you all. Y'all are lovely.
You have your information to give as information.
Yeah.
All right. All right. Thank you, everybody. Have a good rest of your day.